Well, good morning, everyone. Welcome to the policy brief on genomic and precision medicine. As you know, we are basking in glory today because of a number of reasons. One, yesterday, Her Highness announced a CIDRA opening that the Carter Genome Project will be a national priority, and we rename as Carter Precision Medicine. So we're very pleased about that. And of course, you saw the Q-chip today, which is a very important advancement. So I just want to tell you that obviously in Carter, there's a lot of excitement around precision medicine. I'm Victor Zhao. I'm the president of the National Academy of Medicine in US, and I've been very privileged to be involved with Carter in many different ways, certainly in the Genome Project, work with Asma Altani and others to actually bring it to where it is. So welcome to all of you. What I thought I'll do today is I'll have just a very short introduction with some slides just to frame up the issue, and then ask each one of the panelists to speak 5 minutes telling us where they are in their project. And then we'll have a short Q&A panel discussion followed by certainly welcoming every one of you to participate. Let me just simply introduce my panelists. So on this extreme end is Dr. Asma Altani. She is the professor and at Carter University. I believe she's dean, but also she plays a very important role in being the vice chair of the Carter Biobank board of directors, and she oversees the Carter Biobank, in which the Carter Genome Project has been incubating and for the last several years. And she also chairs the national committee, the Genome Committee. So welcome, Asma. Next to Asma is Dr. William Hand. Did I get it right?
Absolutely.
Okay, good. Professor of Hematology at the University of Cambridge, the head of the NHS Blood and Transplant Group, and importantly, he played a really important role in the Genomics England, being the one who actually piloted rare disease sequencing. And next to me is Dr. Asko, who's Vice Director of Institute of Genomics at University of Tartu in Estonia, and also head of the Estonia Biobank Center. So I will quickly show some slides. This learned audience, you probably already know all these issues, but nevertheless, I think it's worth just setting the stage. So precision medicine, I think this is what ultimately we all want to, aspire to achieve. With all the genome sequencing, et cetera, the idea ultimately is to be able to provide our patients and our population with precision medicine. And I won't want to read you this quote from a report that we put out in 2011. And that report coined the term from personalized medicine, personalized health to precision medicine. I think the important issue is the bottom of this slide, which says, realizing the full promise of precision medicine requires researchers, healthcare providers have access to very large data sets of health-related disease linked to individual patients. So all of you know that the human genome was sequenced in 2003, and that really opened up the current era of genomic medicine. With the idea, of course, now, the price being so low, you can sequence a human genome, whole genome sequencing, for possibly even $500, and we expect to be even lower. Now, many individuals, as you heard from William and others, have immediately thought about application of whole genome sequencing in rare disease and hereditary disease, or those that have difficult diagnosis, and also in cancer. As many of you know, when you have a rare cancer that's resistant to therapy, there's been many really good stories about this. Others have taken on to sequence cohorts in cardiovascular disease and cancer, and of course, others have begun thinking about what about a whole population approach. I put down the low part of this slide simply to emphasize again, it's not only about genome sequencing. It's really about bringing together large data sets to really look at whether using data analytic to really have much better precision in prediction, et cetera. So many countries already launch projects and genome projects, precision medicine projects, and this is surely not a complete list. But I would say we're very lucky to have 3 of the leading ones here today: Genomics England, Qatar Genome Project, and the Estonian Genome Project. At US, we have a project called All of Us, which has started about 1.5 years ago, that aspires to look at 1 million US subjects. And maybe if time is right, I'll say a few words about that, how it actually compares to some of the other projects. So at WISH, this has been a very important part of WISH from the day in which Her Highness announced the Genome Project 5 years ago at WISH to, of course, a series of meetings we've had, research forums and others about precision medicine. I think it's important, as I said again, that it is the integration of tools and technology. It is the use ultimately in management of health and disease, not only for individual, for public health as well. It is about creating a learning health system, public-private partnership, and importantly, as this policy agenda briefing, it's about policy and international coordination. So here are some ideas based on many different work, the ones done here and NIH and others, that, if you start from anew, and I have to give Qatar a lot of credit because they started 3 years ago, had to build these blocks of genome technology, data information. A biobank already, of course, existed before. The workforce research, clinical implementation, really importantly, participation of community, and of course, ethics and policy. So ultimately, my last slide says, what are those policy ecosystem? I would say if you want to realize the full potential of precision medicine, evidence generation is critically important. That is getting enough data to create the evidence to show that, in fact, precision medicine can improve clinical outcomes, increase cost effectiveness, and improve quality of life. A lot of hype in this area. One can argue that we haven't really fully seen the potential yet. What's the evidence? Secondly, of course, big areas: data ownership, privacy, and sharing. And of course, ultimately, clinical implementation. How do you integrate into care delivery system? And most importantly is patient engagement and public engagement, the ownership, the trust the patient must have. And in the policy arena, one should think about regulatory and reimbursement simply because diagnostics and innovative medicine will have to meet the standards and the proper level of regulation. And of course, the cost is always in our mind. If you look at the US with immuno-CAR-T therapy, it's $475,000 for a treatment, not counting hospitalization, et cetera. So I think those are the main issues that we'll talk about. And with that, I'll say this is the goals for this meeting. Global landscape, where are we in precision medicine? I'm going to ask each one of the panelists to talk about their strategy and how they feel that they can ultimately reach the goal of precision medicine from the way they're approaching it, what's their successes, what are their challenges, and of course, what kind of policy ecosystem is needed. So with that background, let me turn to Dr. Asma. If you can begin by telling us about where you are.
Thank you, Professor Zhao, and it is my pleasure to be here today with you talking about Qatar experience so far in Qatar Genome. Just to introduce myself, I am biologist by practice. I'm not genomics, but I learn a lot also during this journey. Okay, can we start with my slides? Who's responsible here about the slides? Okay. Okay, I'm going to start with the slide talking about what is unique for Qatar to start this project. As you know, Qatar population is very small. We are around, 300,000, 400,000. We have this unique centralized health system. Also, we are working very closely with the stakeholders, and we have very good sequence infrastructure with our partner at CIDRA. Also, we expect that Qataris with the high consanguinity rate, and they are representative most of the Arab population, And we also we have comprehensive phenotyping samples through Qatar Biobank. So all these factors help us to achieve this, to work or to think to start this project at Qatar 5 years ago, as Professor Zo mentioned. Also, what we would like to focus in the second slide, please. Second slide. Okay. When we start thinking about Qatar genome, and this is in help with Professor Zo, who start with us the roadmap for this project. We start from Qatar Biobank samples, and we start thinking what kind of building blocks we need to be together to start this project. So we need good source of samples, which it was the Qatar Biobank. Also, we need good infrastructure for sequencing, and was Sidra provide us with this kind of infrastructure to do the whole genome sequencing and the bioinformatics. Also, we start thinking about the human capacity and what we need for second generation and this kind of professionals. Also, start thinking about who gonna to use this post-sequence data, the research consortium. Then we were working from the beginning very closely with Ministry of Public Health to start to establish genomic policies and regulation at Qatar, and also involved our healthcare provider HMC Hamad Medical Cooperation and interact with them on different level and prepare them to hosting all the outcomes from this project and the clinical integration. And finally, the last 7 building blocks we are working on it. It is the genome hub, where we believe we need to integrate all the sequence, phenotyping, both sequence data, phenotyping, demographic data in one hub, and keep it available for patient, for the researcher, and also for a clinician. Next, please. Okay, so far we, as Her Highness mentioned yesterday, and Her Excellency mentioned today morning, that we finished the pilot phase. And in the pilot phase, we achieved several things. One of them, we achieved over 10,000 genome sequencing. Also, we launching the research consortium, where we working with more than 90 local scientists with their international collaborative, to start using this sequence for their research productivity. Also, we were working also very closely with QNRF, and launching funding programs to support researcher to investigate more in either biological samples that belong to these sequenced Qatari samples, and we launched what we called Path Towards Personalized Medicine, and soon we are working for the 3rd cycle. Also, we initiate 2 graduate programs as a capacity building, one of them with Qatar University, the genetic counseling program, and also the other second program, it is with Hamad bin Khalifa University, precision and genomic medicine graduate program, master degree and PhD. Also, we conduct already 2 large survey, one of them for the public, and the other one for the healthcare practitioner. And the aim from this survey is to understand how the readiness of our population for this kind of a project and what they are expecting from us. Also, we were from the beginning trying to make sure that to involve the clinician in this project and find out what kind of obstacles will face them in the future. And mainly it was around two main obstacles. One of them, they want more educational and continuing professional programs, and that's what Hamad bin Khalifa University going to provide. And also they need more genetic counselor in the field to help them to deliver this information. Also, we start drafting the first program, working with Ministry of Public Health and working with the consultant, international consultant, helping us in this policy. We are now focusing on internal and local, but also we are thinking on international in the future when we need to collaborate with other national genome around the world. Also, we achieved what we call it genomic report, personalized genomic report, which is focused on wellness and pharmacogenomic variants. The last achievement and the things that was talking about yesterday and today, it is the Qatar chip, where we collect more than 620,000 gene variant on the chip. And we from the preliminary finding, we found that there is a lot of discoveries still need to be done with this chip to lead us for the second version of Qatari chip. So there will be serial of Qatari chip starting from the first one. Next slide, please. Okay. What is the impact of this Qatari chip, genome personalized project, all these outcomes from 7 building blocks? We are working now very closely and we are focusing on clinical implementation. And we believe there is some tools help us to do this implementation. One of them, the Qatari chip, where it's going to be part of this one, it will be for diagnosis, and this will be done with Hamad Medical Cooperation to start validation and get accreditation for this part. The other part, which is I think we need a lot of researchers to start working with us and the discovery of research outcomes from the chip. Also, we are start talking with the national cancer programs, especially for breast cancer, to help us to do some kind of like screening program out of these post-sequence data. Also, we start focusing on disease and cohort disease program, and we start with Dr. Jassim Al-Suwaidi, collecting 10,000 samples from heart disease patients. And the last one, it is personalized genomic report, where we focusing on the wellness and pharmacogenomic. We are focusing now on 15 drugs with 77 gene variant on the chip. But in the future, we are gonna to continue with the pharmacy department from HMC to find out what is the most gene variant for the more common drugs used in Qatar. The next slide. There is 2 more slides. I think I need to finish it. Yeah, I need to finish it because I have to leave by 12:30. So because this will be question for Professor Zhou, so it's better now to answer it. Okay, what we gonna to do? What is the phase 2 at Qatar Genome? In Qatar Genome phase 2, we're gonna to continue with Biobank to sequence their samples. And mainly the target will be to reach 20,000. That means we're going to cover 10,000 of Qatari population. And by this figures, we believe it is a lot for our population to understand about their health system. Phase 3, it will be population phase, where we can start thinking to approach people from primary health care. And we believe that it could be we reach more than 150,000 with the technology costs becoming lower and lower. The last slide, shall I? Sure. Yeah, thank you. So I think what we are in, I think the last part, it is what we're gonna to focus on it. So since we start with the building infrastructure, we have the Qatar Biobank, we have the sequencing lab infrastructure, and also we have good bioinformatics team, etc. Start working with the publication strategy, either with internal or collaborative, either internal or external. And also we have funding program. Also, we start showing some impact, and this is through Qatar chip, wellness genome report, and also starting with heart disease population, focusing on their pharmacogenomic part. Also, we believe that we, as Her Highness mentioned yesterday, professional security, and what we mean professional security, we are not working on only in building infrastructure, but also we are working in building our human capacity. And this is by providing more genetic counselor in the market, either for private sector or for the government sectors. And finally, the large-scale clinical implementation, it is by going more in pharmacogenomic area, trying to implement these finding a newborn screening tests and pharmacogenomic and premarital test, and finally start to thinking about more complicated disease. Thank you very much, and sorry for the long.
I would say that in the span of 3 short years, you've accomplished a lot. Because I certainly remember at the very beginning, these building blocks were not there. So I think the lessons learned here is that if you really aspire to move this whole field in clinical application, you have to have these building blocks: information, sequencing, clinical implementation, education, workforce, you name it, report, survey. You didn't talk about ethics and policy, right? I know you're working on it, and others. So very impressive. And I think a seminal achievement is the Q-chip. And Andy Brooks is here. I need to give him a shout out about his good work. All right, so let me turn to you, Willem, and tell us about Genome England.
It's maybe good if I get the slides on. Yes, thank you very much. Maybe I should start introducing myself. I'm Willem Ouwehand. I'm a professor of hematology at the University of Cambridge and at the Sanger Institute in Cambridge. So I think, thank you for asking me to comment on the 100,000 Genomes project. I think it's rather, after what I've heard happened here in 3 years, this is a small project for a relatively intermediate-sized country. So let's look at what has been achieved since in 2013 we started. If I can have the first slide. I think I want to focus my presentation on rare diseases. For two reasons, maybe I should take control myself. There are many rare diseases, probably well known here also in Qatar because of the high level of consanguinity. The estimates are 7,000, that's probably an underestimate. In the UK, we have now better traction on a population of 60 million, 3.5 million people have ill health because of rare disease. So I think the first thing we together need to agree to get rid of this misnomer rare disease. Yeah, something that happens in 1 in 20 people in society is not rare. And we isolate many of those people by continuing to use the word rare. Underlying genes, I think this statistics is for those 7,000 diseases, I think have no traction on 4,000. This number of genes not yet identified for rare diseases, well recognized clinically, is reducing day by day because of initiatives here in Qatar and other big projects in the States and in Europe. I think there is a big medical need. For the patients who have connected with the rare diseases program of the 100,000 Genomes project, they had 52 medical contacts before they engaged with the program. Why? Because there's this long windy road of this massive diagnostic delay where mothers generally are sitting with their ill child in clinic waiting for 2.5 years before there is a conclusive molecular diagnosis. And I think we're all well aware that for a large number of parents, that journey can actually be much longer. And then at the end of the journey, there is often still not an answer. So how were we tackling this unmet medical need is, I think for the 100,000 Genomes project, like for the Qatari project, there were some very clear main aims. Reduce the diagnostic delay from 2.5 years to 6 months. Maybe that is not ambitious enough, but why don't we start there? Let's bring whole genome sequencing in a healthcare system, take it out of research and move it into the service so that it becomes available at the front line and doctors can order that test without complications. Report the results back to the clinicians. Don't put them in high impact papers. that are published, maybe also, but why don't also tell the clinicians? And then use the data that have been aggregated across the country to identify the missing causal genes so that the journey for developing new interventions can start. So one of my scientists drew this picture for you, where you have this continuous loop of patients, thousands of patients being connected, DNA being sequenced in a single center, really important, same as here, one genome sequencing center, all the data aggregated in one single supercomputer with a big team of clinical bioinformaticians. And then we process the data, and they go either in the blue loop, as you see to the top, if there is a mutation found that explains the rare disease in the child or the young adult, then it goes through a normal multidisciplinary team of a doctor in blue, a nurse in red, and I think the nurse should become the clinical counselor. I don't think this should be different disciplines. And in green, there is a clinical bioinformatician supporting this team. And then at the bottom, the orange loop is the loop of discovery that is available because all patients have consented that the data can be used in research. So you can have this continuous loop of gene discovery to better understand the link between our DNA code and your DNA code and the consequences this has for your health and ill health. I thought there's a risk if you do 100,000 genomes that I talk about big numbers. I thought I deliberately wouldn't do that, so I scaled it down to tell you a bit about the first 13,000 genomes where we have completed the analysis. So we took rare diseases of the eye, together with Moorfields, with Peng's group. We took rare diseases of the brain, particularly neurodevelopmental, rare disease of the lungs, focus on pulmonary high blood pressure, rare disease of the heart, particularly myopathies, kidney rare diseases, and then a large number of rare diseases of the immune and blood system. And I just thought I would show you one slide what this means for patients. Yeah, so that we don't make only this talking about genomes. So the data went back to the referring clinician, didn't stay in the research space. So let's take the patients from Moorfields Eye Hospital at the top, 728 patients that all had premature blindness. 6 out of 10 got a conclusive diagnosis based on their DNA sequence. That has doubled. That was before we started. It was much lower. Then look at neurodevelopmental, is much less good, maybe. You can say 1 in 5 get a conclusive diagnosis, but there are examples where this has profoundly changed the management of these children. And then we have 4 projects where we said to the clinicians, don't bring patients with known rare diseases. Let's go on a gene discovery. And in the last column, you see we had good evidence of gene discovery where we helped to improve diagnosis for the future. So the 100,000 Genomes project where we now, by Christmas, we will have done 100,000 genomes. This is a snapshot from August that I show you. 81,000 genomes done, 17,000 for cancer patients, 64,000 for rare diseases. And these are real patient samples. These are not samples that collected as part of a research project, that are just patients attending clinic in one of the 200 hospitals of the National Health Service. We have returned 20,000 clinical reports for rare diseases. We have returned 6,000 reports for cancer. And cancer, we can share with you a lot of the challenges we have encountered, why that implementation journey was more challenging, even more challenging than the one for rare diseases. And I think, like here in Qatar, we have now given access to, at this date, this slide's from August, as I mentioned, we have now almost 2,000 researchers from around the world are working on these data because they get access to our Safe Data Center to work with people. And this is about how do we share data safely while maintaining trust of our populations. So I think I can, what now? Because that's what you asked. What's the next step? So the next step is in the last column. The government has committed last month to sequence 500,000 healthy people between the age of 60 and 90. And we go to the National Health Service has secured 500,000 genomes to do the first 4 years for rare disease diagnosis in the real world, so not in the research setting. So I think we have made the implementation step, and we're obviously really keen to work together to make this journey. Thank you very much.
I think it's quite interesting to look at the two approaches. We'll talk about that a little bit. It should be emphasized that the Qatari population are people who are actually Qataris descent, I believe, right? It's about 250,300. So by your 10%, when you get to 20,000, you're 10%. So if you look at your numbers, going up to 500,000, that's still not 10% of population, but certainly you are aspiring to a much higher number, yeah?
I think if the million are done, then we have 1.5 million on 60 million, so that's 4%. And the government has indicated another 4 million, but that needs to be signed off. Yeah.
Thank you. So we're looking forward to hear about Estonia, because it too has a biobank that you run, yeah, with lots of important samples, and of course you right into genotyping. You have a chip, I believe, and also sequencing. So, Dr. Asko.
Yes, thank you, Victor, and thank you to organizers for inviting me. I also come from a fairly small country, so it's easier to get the percentage is, very nice. So the Estonia population size is 1.3 million, of which roughly 1 million are ethnic Estonians. And why Estonia is very special is that we have, since we came independent from the Soviet Union, we were able to build everything from scratch, including the IT systems that now have revolutionized the reuse of the data, but also providing public services. So there is only 3 things I cannot do electronically: is getting married, getting divorced, and buying land. Everything else I can do electronically, including taking bank loans and submitting my taxes, which takes, by the way, 2 minutes, and I get my money back in 2 days without paying a single penny to the government. So this is what, I think it's a good demonstration how automation and integrating the data in the benefit of the citizen can really make a difference. But my presentation is a little bit more a philosophical one, because here we focused, my previous speakers focused mostly on the rare disease or cancer, but this is actually just a 5% of population, but we are very often forgetting the 95% of a population. Then when taking the numbers together is actually also a massive burden for the healthcare system, but also really damaging for the citizen. So this is just a very a simple cartoon to demonstrate the importance of genetics. So every one of you are born with the genes. Sometimes it's surprising, but indeed there are genes in us. And good news is that no one has all the bad genes. But the bad news is that everyone has some bad genes, which means that it's important for us to know what kind of bad genes we have. If we don't have those mutations that according to rare diseases, that are roughly 5% of the mutations at our birth, we still have some bad alleles. And so if you know our level of risk, but then if we get age, we start to practice unhealthy lifestyles, including, less physical activity and bad diet and so on and so forth, at some point the picture of risk becomes full. And then what happens, we become ill. So I think also what is important in healthcare is to act before the citizen becomes a patient. And that's where there are like several terms. It's like precision medicine, and this is, I think, presents the way where we can diagnose the disease or we can prescribe a cancer medicine. But I think what's also a little bit different term is actually precision healthcare or stratified healthcare, where we could actually act before the citizen becomes ill. And there are many examples where this can be implemented, and there are on the model of using polygenic risk score, it's a sum of thousands of risk variants in their genomes. And so what we have been doing in Estonia, we currently have a collection of 50,000 Estonians, so it's already 5%, but it's, as I said, very easy to play with big percentage where the population size is small. What we have done, we have summed up the polygenic scores. This is an example for type 2 diabetes. We have done it for cardiovascular disease, breast cancer, and then you can actually rate yourself or the citizen based on the risk, and then act before the symptoms start. And we have gotten from the questionnaires that actually citizens are much more motivated to act when they know their genetics, because it's not just statistics, it's their genes, it's their future. And the same way, already mentioned pharmacogenomics and the importance of it, we have seen in Estonia that 98% of citizens have at least one pharmacogenetically important mutation. And I think implementing the pharmacogenetics in the system, like in Estonia, it's very easy because 99.99% of all prescriptions are electronic. There is literally one doctor who doesn't use electronic system for prescriptions. So actually implementing this kind of already electronic information in the pharmacogenomics in the prescriptions, very easy. So what we see as a future is that, like already Owen showed, is like actually everything has to be integrated together. So it's like a vicious circle where new knowledge feeds into the healthcare, feeds into the research. At the same time, data generated goes into the research. And we have sold this model for the government, and since April this year, we got funding to increase the biobank by 100,000 citizens, and everybody have array-based profiles. And meeting last week the Prime Minister, I got the news that we will get another set of funding to actually increase the biobank by another 100,000. So by the end of 2019, we will have 250,000 Estonians, which is roughly 25% of the adult population. And we are now working ways how to get this information into the healthcare system, either through primary care, occupational health, or pharmacists. And the last slide is just to show very briefly that we are there to implement personalized medicine or personalized healthcare, because the IT is there, the technology is there, the political will is there, and I think what most importantly, the citizens want it. So we have a big queues, long queues behind our facilities, so that I think the queue is 1,000 people, and it 3 months timetable fills in like 5 minutes. So people want their genes back, and I think we shouldn't keep it from them. So thank you.
Thank you. Fascinating. So Qatar use a biobank approach, and they actually deeply phenotype. There are 30,000 now, right, of people in the biobank samples. 17,000. Actually, Faris, it would be great to have another microphone, because we're going to try to pass back and forth. Anyway, so biobank, and you start off with rare disease. So at the end of the day, there's no question that populations benefit from this approach, whether rare disease, cancer. But I think most people's aspiration would be that it's actually going to be used in everyday healthcare. And actually, you mentioned precision healthcare. I say it's precision health and public health, right? So the question is, can each one of you talk about how you expect to get there, particularly we talk about electronic health record, the integration of data. How are we moving in this direction? Maybe, Willem, we can start with you first in Genome England.
I think this is a good question. How do we take forward now from target projects like Genome England and UK Biobank, which are together the big flagship projects in the UK, to population-based? And I think maybe therefore it's good to expand on what is the next step. So the next step for a country of the size of of England with 60 million population is to try to get 10% of the people connected to the bioresource and to make that more participatory. Do we have experience with this? We have connected 150,000 people with the bioresource that all have been genotyped, and many of those people are participatory in the sense that was described by my colleague from Estonia. So I think the step is from now in the next 2 years to grow the bioresource by 1 million people. That allows us to start doing the modeling that will be needed for the polygenic risk scores. Do you say have choices been made? And then I think I should round up. I think breast cancer would come very high, probably as a first public health intervention where polygenic risk scoring would come in. Has the second area been chosen? If it was my choice, I would say cardiovascular diseases, particularly stroke and vascular dementia. I think it was discussed this morning during the opening, is this with vascular dementia, we can't wait until the dementia is there. We need to go much more to a prevention program for dementia. So I think that might well become the two choices.
So, Willem, what's the state of electronic health record in the UK?
Abysmal. Sorry, I'm Dutch, so I can be honest. I hope there's no... I think our Prime Minister is not in the room, so why can't I say so? It is excellent at the level of the GP record. So if you in England want to go to see a doctor in a hospital, you must first see the gatekeeper to the NHS, which is your general practitioner. And 98% of the population is on the general practitioner registry, and that is now linked to our genome data. So I think there we are in great shape. We are in really bad shape with our hospital information systems. So Cambridge, the big hospitals of London, they have either gone to Epic or to Cerner, so we are moving, but we are running behind. So I think again there, here in Qatar, you're on Cerner, and we need to have joint up discussions with these companies about how we do this early translation. And I was, if you allow me, just talking with Xavier about an early translation. We have worked with New York and Boston on translating out of the genome the blood groups, the tissue types, and other acute medicine information to clinical standards. We now need to take this to FDA approval, and then we can jointly with Cerner and with Epic work on this implementation, because they're not ready as companies yet.
Dr. Asma, you highlighted at the very beginning that actually you have a single health system, and in fact there's been very much a lot of activities building this under Her Excellency, right? So tell us a little about how you imagine taking what you do now from the biobank side and sequencing into actually the clinical side.
Actually, I think I cannot say more than what Her Highness mentioned yesterday in Sidra opening. And she mentioned that Qatar Genome, it is not now project anymore. It's going to be as a national health strategy. And it will be for a national health strategy for Qatar Precision Medicine. And this will be the owner or the leading for these two projects. It will be Ministry of Public Health and Qatar Foundation. So that means it will be integrated in most of the ministry agenda. It is not in education and finance and health. And we would like to build on what been already established. Maybe we need there will be some kind of prioritization things. Definitely, policy and regulation will be priority now. We need to take it to other level, especially if we're going to think about international collaboration. Still, we are not at mature stage to do that, and this need to be more focused. Also, we need to work with finance and HR and different healthcare provider to create more position for genetic counselor, genetic physicians. Because whatever we're going to put as a plan for a clinical implementation, if we don't have support from budget and from building capacity and academia, and also definitely the researcher, will not be doable in the future.
So Tono, I think that she raised a number of questions, which is what in fact is I call it loosely governance over this? In other words, as Dr. Asma said, look, we're coming together, entire nation is no longer in the research domain or this. We bring the ministries together to oversee this entire project, right? It's a national priority. What is it in Estonia? Is it mainly now still in the kind of under science and technology? Is it under health system? How do you actually integrate the many different pieces together? So that's the first question. And then if you can answer the second question, capacity. Estonia is not a big country. Qatar is not a big country. How many genetic counselors, or do you need genetic counselors and people who have the ability to understand genomic medicine, if not at least the technologist to do the sequencing, the informatics, etc.?
So to answer the first question, so I think the real stakeholder is still the citizen. So if the citizen trusts the system, then a change is possible. And in case of Estonia, citizens trust the system very much. Almost 40% of all votes electronically. But but we are also now working, actually are in the phase where it's not anymore a genome project or genome initiative, but it's actually moving into the healthcare, because in the scientific realm we can only show the way, but we shouldn't definitely be the people who implement it into the healthcare. We can provide the knowledge and what we think how it should be implemented, but in order to foster the chain, it has to be led by the medical doctors. And now we have on board, several of the ministries: Ministry of Health, Ministry of Science and Education, Ministry of Business Creation, Prime Minister. So it's really, becoming a national pride to be part of the Genome Project. And I think our vision, or at least my vision now, but I'm trying to, spread this vision, is actually to get everyone genetically profiled as quickly as possible. And as the numbers are small, it's doable. And the second question was like how many genetic counselors we have at the day. It's exactly
overall capacity, work capacity.
Yeah, but I start with the medical geneticists, 12. So even a population size of 1.3 million, 12 may be enough. But I think it's not about training that much more medical geneticists, but it's actually redefining how the genetic information should be provided to the patient or the citizen, because I think medical geneticists are, like Sherlock Holmes. They go after very complicated cases which needs expert knowledge. But if you're talking about pharmacogenomics, or if you're talking about polygenic risk scores, it's just like the same thing as you are smoking or you have a high LDL cholesterol risk. So in principle, the risk is exactly the same. So it's just on how to convey it. So I think what we are doing in Estonia is actually trying to educate primary care professionals to be fluent enough in genetics to understand it, maybe even revolutionize it more going into the occupational health doctors, because their task is to keep the citizen or the worker healthy. It's not actually the primary care doctor's problem, because they already are treating, but they don't want to keep them healthy because the paying system is different. And why not to go directly to the pharmacist, who are actually 5 years training in medicine, and they can do this counseling as well. And the pharmacy is very close to the citizen. And maybe last point is that, again, to the UK colleague, we are actually doing 2 pilot projects, both actually in breast cancer and cardiovascular disease, focusing on the high-risk people with high polygenic risk score. And last point, whichever disease you take, if you focus on the top 1 or 3% of the polygenic risk score, those people have on average 3 to 8 times the risk for the disease than average population. And if you target them somehow, you will make a change.
So Willem, Tono is saying that we can train all the doctors and providers in at least faceted in the use of, risk and genomics and you name it. I would say last time I looked at United States practitioners, Many of them don't even ask for a family history. So what are you doing in UK if, in fact, you need to deploy every provider to be involved with this?
Okay, I think first, if you build a system for the future, you don't use the systems of the past. I think Estonia is showing this us beautifully. So I think this call for training more and more, and I hope there are not too many clinical genetics counselors in the room, because I might say something that's very upsetting. I think it is wrong to train people that were trained for an era of the first 5 years of genetic Sherlock Holmes, where we had a very isolated clinical genetics community who worked on children that had severe rare diseases, and there was counseling was brought in. Much more, and that I think is where England is going, is you train the workforce that needs to know. I go to tell you a personal story. I've never seen my GP, I've never been in a hospital, except professionally. But last week my GP phoned me about my Q score. And my Q score was 12.8%. And therefore I needed to discuss with you whether I go to use statins or not. And I think I don't see a difference. If I get a Q score based on my lipid measurements and based on my age and based on my physical activity, and then get an advice whether I should start popping statins or not, it's really not different whether that Q score would also be informed by my genetic code. So my mother had a stroke at very young age. My father lived to great age and had no stroke, neither heart attacks, and smoked like a chimney. So I really need to decide. And I fully aligned with the Estonian model. It is wrong to train clinical genetic counselors, because other omics platforms that have nothing to do with genetics except that genes control it will come in. And then we have trained these people who are experts in ACT and Gs who have to tell about peptides. I think it's the wrong direction. We need to educate the population.
Not to disagree with you, but to be controversial, I'll say that the average physician is so busy that you're expecting them to be spending the time and the realization of all the stuff, right? So I agree with you. That's the aspiration. And maybe with artificial intelligence and electronic stuff, that can help. But let's face it, your rare disease populations still need a lot of counseling. So you can't say they don't need counseling. The question is, what percent do you need? What sort of population?
I think if my child, so I live with a family in Cambridge with 2 children, 2 young adults with severe cystic fibrosis. I think they are continuously seeing their medical care providers. I think the knowledge should sit in the medical specialization that looks after you, because otherwise we miss the point. We let patients go from station to station to station in the care provision model, and I think we need to find smarter ways to provide this.
Thank you. I think as we are talking about precision and personalized medicine, we need talking about also about precision and personalized healthcare system. What can be applied in Estonia it could be applied in Qatar, or it could be not. And I believe when we was thinking about initiating genetic counseling program, the statistic was done, and we found that on the ground we have only 3 licensing genetic counseling, while currently we need 26 to cover all the cancer clinic, all the rare disease clinic, all the heart disease clinic, who they start using pharmacogenomic data. So definitely we should be flexible, and that's why we initiate another program which is called Precision and Genomic Medicine and HPKU. And the aim from this program to train the physicians and nursing and healthcare provider to start using this both sequence data and their practice. But until we reach the stage of the Estonia, how they are advanced in their IT system, and I hope England reach this stage also, we will be more than happy that if they have protect time. But upon the survey that we conduct, the main obstacles the healthcare provider told us, we don't have a protect time to attend these courses you're going to initiate it, We need genetic counselors to help us to deliver this. We don't have time. We need to see at least maybe 50 patients at the day, and we don't have time to spend with them 1 hour to explain for them what is the outcomes.
Right.
So I think we need to be realistic with our local needs, and to tailor it according to our requirements. Thank you.
Yeah. So we're going to open up for a general question. So get ready. And I know that Dr. Asma needs to leave earlier, and I'm looking at either you, Asmal, or Dr. Nala to sit in the seat and to continue this conversation. So if I may, let me ask you one last question before I open up. Patients, or the people, right? I mean, we talk a lot about, from a system viewpoint, serving the people, yet trust and engagement is so important. So talk a little bit about what you've done to engage the public, what's their attitude, and how do you assure them that the information you're gathering is not going to be misused, right? A very important issue. And of course, the other issue, in my opinion, is whether we are actually looking at a really representation of the population as we bring these people into certainly the research phase, if we will, of genomic medicine. So, you want to start first?
Yep. What I wanted to say, I didn't say that there is no need for genetic counselors. What I did say was that not all the... Willem said that. Not all genetics has to go through the genetic counselor if it's an easy case.
We know that.
Anyway, so about public outreach, and I think this is really, really important, and this is, I think, also part of the fact that why we can start to think on skipping, in some cases, the genetic counselors and go direct to the GP or pharmacist is actually we have done 20 years of genomic education. So on average, we are like 400 times in the public media per year, including like newspapers, news stories. We were also in the most popular soap opera just to get the elderly retired people into the biobank. So it's really like, talking about genetics, demonizing genetics. And now we are even thinking ways how to open the genetics data up in a safe way so the data is not breached, but so that the participants could actually buy services from different service providers who interpret the genome. Mm-hmm. But it's not that the genome doesn't go wild and the safety is breached. But you also has to safety. It's again like there has to be a system how the data can be safely shared, because this also, if the data is shared and systemized, it can be used. So it's not that the GP has to look the data, but the system tells the GP to call a patient, or maybe the system calls the patient without even interaction with the GP, if the algorithms are so smart. And maybe blockchain is here the key. It's not about restricting everything, but it's actually the ability to track the movement of the data, because if someone unauthorized used it, you can...
I have to respond to you. I know other people are going to answer my question, mainly because we just went through midterm election. Our biggest concern is hacking, so imagine that all this electronic information everywhere is so vulnerable to hacking attack and security, etc. So just to be fair, we really have to be sure when we move this direction that we can actually enable the security and the trust of the patients, right?
Yep. And actually, Estonia was the first country officially cyber attacked globally. So we know about the hacking, and actually I think our data has been never hacked. And there has been like maybe 5 cases where the data has been misused. So it's really about the visibility, but of course it requires very good cybersecurity, very clever encrypting systems in order to implement it. I'm not saying that let's go electronic now, but there has to be very, very good systems underlying there.
Well, we can all learn from you because, as you know, in Singapore, they hacked into Prime Minister's health record and 1.5 million health records. So it's not a trivial issue. And at least according to Singapore, there is a, shall we say, a concerted effort to demonstrate they can hack the prime minister's record. I won't say what state that did it. Okay, so what do you think? You had a really interesting survey, right?
I think we are working now very closely with CIDRA to have this kind of security, and we're trying to make it more centralized at this stage, not only because for cybersecurity, because also we don't have still this kind of regulation yet mature to understand who should be shared and who should be. Although we have this material transfer agreement where we trying to control who gonna to access and for which purpose, and but still we are in the process to make it more mature in this stage.
No. Willem, any things about patient engagement, public engagement?
I think first, the best thing is to admit you made maybe an error in pronouncement. Obviously, we do need clinical genetic counselors. I think we do also need to democratize the knowledge.
Yes.
And one of my colleagues in genetics actually said, maybe they will be the role like the radiologist has. If you have an X-ray that's really difficult to interpret, you call them in for consultation. But we really must democratize. So how does the UK do it, and have we done it particularly well? I think we have used the BBC, we have used ITV, we've worked with the media. Have we been strong on Facebook, on WhatsApp? I think there we really miss a trick. Vivian Perry has tried to work with the more modern media that are used by the next generation. And I think there we need to get smarter, because being on BBC while all the kids till 45 years of age are looking at something else is not very helpful. And maybe we can learn there from Estonia or from other countries that have worked effectively with Facebook and with WhatsApp and other platforms to educate people.
Great, thank you. Many other questions, but I think there's been a great dialogue. I think the emphasis here is that eventually what's useful in all this information is what you do for the patient and the public health. Critically important issue. And it's not about genome sequencing alone, which is really a technology that is now fundamentally getting quite easy. As long as you can afford it, you can do it. But it's building together all the other systems around it. Questions from the audience? There's a microphone going around over there. Yes.
Yes, I have a question regarding also the public and the trust, especially here in Qatar. What are the tools you have, and how are you trying to attract people to do this and to trust this?
Sorry, I didn't answer the last question regarding how to engage the public, but I think, I already answered it by conducting the large national survey. We cover a lot of majority of our population, and the response was 71% they are willing to contribute in this one. And I will take from my colleague from Estonia that definitely how we engage people, they trust so far in the government. And we found this positive experience from Biobank. When we start Biobank, we were expecting that who gonna to donate 3 hours from their time to come and to donate their samples. And the waiting list now more than 5,000 or 7,000 sometimes waiting for their come and to contribute. I think this kind of good relation with the government and our population, this is what will encourage them to contribute more and more in Qatar Genome.
I tell you what we do in US, all of us, I think, is making a really impressive effort to have the public volunteer to join the whole project. And they've, I think I would say the first phase of building this million is actually focused on public engagement before sequencing, before everything else. And importantly, they reach out to minority populations, Asian organizations, many other population, just so that they can actually have as much engagement as possible and the representation of the population, in terms of ethnic and race. So I think that's a really important issue to be considered. Other questions?
Yeah, first of all, thank you very much for that great overview on an international scale. With regards to that citizen participation, so I believe one specific thing, what I learned also from HMC here in Qatar, is that you can access your personal healthcare data already online. So how do you plan, and this might be also the first step, to give something back? How do you plan to include also like these personal genomic records in that system, so that once you have been sequenced, you have also the possibility to see it on your own, maybe ask a counselor, maybe share it with family members to get something back that you say, this is my piece of the cake I can use personally, share with research or with whatever partners. Because I know from the US this is very popular, right?
Yeah.
If you remember from the slide, we already talked about the Genome Hub, where we believe that it's going to be accessed by the patient or participant, by the researcher and the clinician. But definitely there will be different level of security and coding system.
Other questions? So actually, he asked a very important question, because in our country, the commercial sources like 23andMe, they can send your DNA a swab, and then you not only know about your genealogy, but you know about a lot of genetic information. What overall, I see you're ready to answer, that's great. How do you see this? And then, of course, once you have the information, what do you do with it?
So the answer about the data ownership, I think in EU by the General Data Protection Law, all the data is owned by the citizen, and the government, whoever, is just using it for providing services. But this question about getting access to the genome data, what back in the days people did, they just took a snapshot from 23andMe and then posted it on Facebook. All their risks and no concerns whatsoever. At the same time, everybody's concerned about their data being stolen and so on and so forth.
True.
I think it's important that the data is in the hand of the citizens, but they have to be educated. And the approach that we took or will take in Estonia is that at some point they will start to receive automatic updates on their genetic risks. But there always has to be at least once a face-to-face meeting with the professionals, just that they understand the consequences of the data. And the other aspect is that do all the services and interpretation be developed by the public sector? I don't think so, because we have like many other things to do as well, so we cannot do all the development. So I think it's crucial to open up this data for private entities as well, so they could develop the services. But there has to be some kind of regulatory framework that not everything can be, provided as a interpretation, because then we are in the area of fortune tellers and other lunatic people about looking at your hand and reading all kind of nonsense out of it. So I think it's important to keep in mind.
Okay, so William, I'd like you to try to answer this question then. Ownership. Tono made a strong point, citizens own it. I'm not sure whether I really understand that or not. That is, one extreme end would be, I own the data, and if you want access to it, you need to ask me for it, right? So we say a lot in the United States, patient own the data, but truth of the matter is, you have to go to a health system to ask for the information, not the other way around. And ownership in general means you have the right to do whatever you want to do with it. It's your own, including selling them. Because we're very concerned in the United States and elsewhere that Google and Facebook are collecting our data, and then they use it, in fact, for commercial purposes. But if we take the extreme argument of ownership, can I actually in Estonia sell my data to Pfizer?
Yeah, if you want to.
Okay. That's interesting. I'd like to see a show of hands for what people think. Go ahead, answer the question first.
So be careful on ownership. So I think first, principles. The best thing is that I share with you the experience of the UK. What do? Is if people join the biobank or what is the new buzzword bioresource, what's the difference in biobank, you are non-participatory, you provide your data but nothing comes back, while in bioresource you donate your data and you can get back and you can be invited to participate. So the future is about bioresource participatory. If you become a member of the bioresource, you donate your data as a free gift to society for the greater good. To that donation, no strings, I've written the sentence myself, no strings are attached, you will have no earnings, or you will not have any rights in the data, and that is what generated from the data. Inventions may be made and may be protected and will be worked with big companies to make better treatments and diagnostics for patients. So that is in law, you have given the ownership to a legal entity which is not for profit, but can work with other organizations to optimize the use of the data. I fully agree with Victor, with your position is under European law, you can say the data are owned by the individual. I agree with that principle, but we break that principle by asking people to become a member of the club. Good. My daughter was on Facebook. She got pretty addicted to it, and then she said, "Daddy, I need to change this." And she said, "I go off Facebook." So you can become a member of the bioresource and be a friend of the bioresource. And we make very clear to people you can withdraw on any moment in time. You have no reason you have to explain. This is a clear divorce settlement. There is no dispute. But don't make promises. We will say we will not use your data anymore for the future. But your data have been shared across the world. There are 10,000 researchers in the States, in Europe, in France, anywhere that use UK Biobank data. I can't promise that that particular researcher in Estonia who uses UK Biobank data will stop using those data. But we will not give permission to have your data used in the future by other people. So my advice strongly to all of us in the room is don't make promises that you know you cannot fulfill, because then the contract will be broken and the population will become angry with us as professionals. Second, I have a mobile phone. I assume I'm not an exception in this room. Apple knows that I'm here. Apple knows that you're here. We all know that TalkTalk had a massive data breach. So don't promise that there will be never data breaches. Where's the arrogance that we can protect our data centers better than the professional hackers that are hired by governments to hack in? Or if I want my bioinformaticians trained in hacking, I send them off to a hacking course and they hack into MI5 within the first half hour. So it's just a joy to hack. So don't make promises in the agreement with your citizens that you know you can fulfill. Be honest like you are with your children. Yep. Yeah?
Okay,
Because
other questions? I think there's one way back there. Oh, please. You have to leave, yes. Who would you like to represent you? Dr. Saeed, come on up. Thank you. Thank you. I'll join you very shortly also. Dr. Saeed is the manager of the Qatar Genome Project.
I think my question has been answered already, but it was more of a comment on the genetic counseling versus clinician or being trained how to counsel patients. I think the ideal, optimally, is yes, to get the clinician to be trained enough, have the enough interest, and actually counsel their patient for many reasons. One, because patients trust their physician really highly and are more likely to listen to them. And because they are the same people who have been dealing with their disease and talking to them about how they can diagnose it and treat it and everything. However, there is a huge gap yet to be filled. Genomic, to many physicians, most of them, is a new milestone. The level of interest among physicians in genomic and genetic is very variable and mostly not that much. At this stage, I'm sure it's going to grow. That's why I think they complement each other. So I think we need to work in parallel, training new genetic counselors, which we would need for complex cases, and more in this era where people are not yet, at that level, clinician at that level where they can all be willing and have time to be trained and counsel patients until we eventually, have enough time, enough budget, enough money, enough training, and then in 20 years maybe this can be purely actually clinician, physician who the patient trusts and who they know the patient very well, and the families who can actually also counsel the patient. But yet you still need a small number which can deal with very complex cases, as you said. So I think they complement each other in this.
Thank you very much.
Doctor, if you just allow me to say who that. Dr. Amal was the clinical head for the Qatar Genome Project. She defected and she's now back to her clinic at Sidra. So in her time with the Qatar Genome Project, she was responsible for the professional survey, national. She's the one who take a careful look at the questions being asked to hundreds of physicians around Qatar, and she's the one who knows exactly how they came back and answered. So I would only second what she said, is that actually 85% of those physicians and healthcare professionals surveyed said, no, at this moment we either need more training or more genetic counselors in our departments. So it's basically a transition period for that to reach that level.
And quite frankly, if you look at the long run, as we keep saying, it's not about your genes only, which means that you really have to use the tools available to you, which are big data and possibly artificial intelligence for clinical decision support, right? Which means the physician will not have to think about the genes here and there. They just put in the information and use that that's the future, in my opinion, right? We're a little bit kind of focused on genes, but I think it's really a lot more. And precision medicine is a lot more than just the genomics portion of it. Andy.
So you touched briefly on direct-to-consumer involvement for people that want to learn more about their genetic cells, and the types of companies that are emerging to look at our molecular cells is rapidly evolving. In fact, there are probably many more individual companies that will do some sort of testing than there are either government or academic or centralized healthcare applications. So with the community's interest and involvement, which right now is largely around entertainment, but will ultimately involve into learning more about their health, how do you see, who owns the data aside, how do you see people that are concerned about or that want to be involved in their own healthcare generating data like this? How does that integrate with all of your programs, and how do people get more involved with their own healthcare? Not worrying about owning their data, but about using these other data forms as a function of these large genome and healthcare programs.
Why don't we start with you first, Saeed? You just joined us.
So you've seen the reports Dr. Asma showed. For us, the way we see it, the general wellness reports and then the pharmacogenomics reports, we see it as Qatar Genome and Qatar Biobank as a learning experience, so that we build experience, but eventually we know that we have to let go of that. But we are gaining experience to be able to monitor the market. And we know that the private sector is better suited to serve the public and the growing interest. So as Qatar Genome or Qatar Bank, we have no plans to sort of monopolize or have control on that, but we're just building experience and knowledge so that we can monitor, so that we can advise the government. But we can see the public, the private companies coming into Qatar, yes.
Yeah. Any other questions before lunch break? So let me just ask each one the last question, which is, what were your biggest challenge in implementing your program, and what do you see as the biggest opportunity, going forward next few years? Starting with you, Tony.
I think our biggest challenge was and still is actually to get the funding to realize this vision, because while we are very similar size and kind of population with Qatar, we definitely don't have as much oil and gas around. So we actually have to be very innovative in the ways how we get the funding. And other part, sorry.
Opportunity.
Oh, opportunity. I think the opportunity really is in the case of Estonia to demonstrate that if implementing this, prevention-focused model, you can actually serve the citizens better. And in the end, you maybe cannot save money, but you can use the funding much more wisely towards keeping the citizen healthier or providing better tools and services for the citizen. I think this is the opportunity.
Willem?
I think every country makes its own journey. I think the biggest challenge for the UK was that we had a historical footprint of 26 laboratories providing clinical genetic services, which has now contracted over 3 years to 7 laboratories. So I think that was a challenge, because that practically means making people redundant in laboratories, and people don't like that. I think the biggest opportunity is this, the word precision medicine, where you started, Victor, is to have compelling, well evidence-based, scientifically rigorous programs of stratified prevention of early disease. If that could be breast cancer and, let's say, vascular dementia, then that are good 2 choices. But can we agree together that we need to prevent that we are rushing in this area of polygenic risk scoring without having proper randomized or nested randomized studies? Because, gosh, the companies like selling services, but sometimes the evidence for selling the service is lacking. Yeah.
That's Saeed. Last word.
So Tono, it's an oil-rich country, but I can assure you, and Professor Zhao can tell you, he knows the figures, that we are one of the least expensive, large-scale national genome projects that are out there. The trick is that, and that's the biggest challenge, going to your question, is that the way the plan was laid out is that we, as a small group, Qatar Genome, work with national stakeholders. We make best use of the resources. We work with Sidra, Hamad, Cornell, and everybody else in Qatar. So that was the challenge, to make people align with this 7 building blocks plan. That was a huge challenge. But now we can see it as the opportunity where we can sort of solidify this sort of relationship into more mature, like the thing that was brought by Professor Zhao and Dr. Asma, is basically making the Ministry of Public Health a partner, not only project-based sort of partnership. It's a strategic partner in this project, and it has a stake in that. So that's this opportunity we see.
Well, please join me to thank those great panelists for an excellent discussion. Thank you.